So good morning to all. I have great pleasure in inviting two of my great friends and very illustrious colleagues. The one who's going to speak on headache syndrome, which you will come to know what it is at the end of the first 40 or 45 minutes lecture. Dr. Parameswaran, he's the CEO and chairman of the Indo-American Brain and Spine Center, and he hails from my hometown, Vaikom. And just I can put it in two statements. When I go to my hometown, that is Vaikom, even my closest relatives would prefer to see him for any neurological problems than me. That gives a picture of what he is. And he is a very good clinician, and especially when it comes to very rare syndromes where no one has an answer to the problem. He is one among the Chitra alumni who comes out and cracks the query completely. And these are some of his contributions. And we see around what I heard from my relatives and those people over there is that his OPD is around probably more than 1,000 new patients per week. So that the last 20 years you can count on it. And he runs one of the most active Botox clinics in the whole of the country. And there's much more to that. And so Dr. Parameswaran will be dealing on a specific headache syndrome, and we'll see what it is. And to chair the session, I have another important person, Dr. Sanjeev, who's a senior consultant in Muthoot Medical Center, and was my batchmate and still my closest confidant. And so over to Sanjeev.
Hi, good morning, Asha. Respected teachers and colleagues, it gives me immense pleasure to interact with you all, and I would like to sincerely thank my great friend Dr. Asha for giving me this wonderful opportunity. It's a matter of pride and privilege to introduce my dear friend Dr. Parameswaran. He's a goal-oriented, bold, intelligent, and a hard-working neurologist. He did his UG and PG from Government Medical College, Kottayam, and DM from Sri Chitra. He is attached to Indo-American Hospital in Vaikom for the last 22 years and is currently the CEO and chairman of group of institutions. He has authored many articles. However, two landmark articles on eosinophilic meningitis and the other one on intrathecal rituximab as rescue therapy in resistant NMDR encephalitis needs special mention. Regarding spontaneous intracranial hypertension, his case series, I think, is the largest cohort, at least in India, which consists of 69 patients in which he did epidural blood patching in 62 cases. No doubt he is the right person to talk on this topic. Spontaneous intracranial hypertension was once considered a rare entity and not given priority in the differential diagnosis of headache evaluation. Now we know that this entity is not uncommon. Recently, there has been a surge in the interest in this topic, which broadened the symptomatology, signs, investigation modalities, as well as therapeutic guidelines. If not diagnosed early and managed properly, patients are at risk of developing acute as well as chronic complications and its sequelae. So with this brief introduction, I invite Dr. Parameswaran to deliver his speech. Over to Parameswaran.
Thank you, Professor Ashalada and Dr. V.K. Sanjeev for the kind words about me. Since already 5 minutes, 6 minutes over, without wasting time, we'll go to the topic proper. Before the topic per se, let me talk this lady. His clinical presentation is so close to my heart. This is a 32-year-old Ashwati. He's a tall, 178 centimeter long lady. She had headaches since her degree class period onwards. Severe, disabling, daily, long duration posterior head region, sometimes holocranial headache, and she was forced to stop studies due to her headache. Severe headache and some relief of the headache while lying down. always confined in a dark room, severely disabled due to headache for many years. She was labeled for a long time as non-organic and was on high dosage of mood stabilizers and tranquilizers for many years. In 2015, at the age of 23, she consulted me for the first time. She got dramatic and immediate relief of the headache after the procedure epidural blood patch. She restarted socializing, she started going out of the home, and she was able to continue her BTech studies. And this is the first index case which initiated my interest in this field. This is just to show how misdiagnosis is common, how disabling the disease is, and how rewarding the result is. Let us start our journey with this classical case, classical in presentation, classical in radiology, classical in treatment response, and a one nightmare classical complication. The 32-year-old gentleman, Kurian, he was working as a male nurse in Belgium. He is symptomatic for past 4 months before admission at our center. He was getting treatment as chronic meningitis because of the CSF pleocytosis and headache in Belgium. Initial multiple times proxy consultation by his parents from Kottayam for an opinion, second opinion. Many times. So I asked the parents to bring if there is no improvement because he may need a re-evaluation with a repeat MRI brain planar contrast and a repeat CSF study for a virgin CSF result. But his symptoms worsened day by day and came to our hospital because of the persistent and aggravation of severe headache. He directly came from Belgium from the airport at midnight, and on arrival, MRI brain planar contrast was taken and it just read by the residents. And since there was no contraindication for LPCSF study, LPCSF study was dead by the same night itself. Next day morning, I saw the patient, took a detailed history, reviewed all the previous documents also. And this was the MRI taken in our center on the previous night. You can carefully see the MRI. And what is the diagnosis? Definitely, it is not chronic meningitis, it is classical spontaneous intracranial hypotension. We have 66 cases of intracranial hypotension for the last 10 years after the first index case. This presentation is to share my experience in this fully reversible entity, provided if clinically suspected, properly evaluated, diagnosis and treated. It is often underdiagnosed and undertreated. The threshold for proper evaluation and treatment is still very high in neurology, maybe because of the lack of familiarity with SIH diagnosis, lack of familiarity with careful interpretation of SIH radiology, or uncertainty regarding the risk versus benefit of blood patch, especially in those without a definite diagnosis, classically true double negative or true single negative, or those with a atypical presentation. Before going to the presentation, these are the questions which is easy one should remember. What are the commonest clinical presentation of SIH, commonest clinical radiological feature of SIH? Can venous sinus or cortical vein thrombosis occur in SIH? Can behavioral issues, cognitive decline occur in SIH? What is frontotemporal brain sagging syndrome? Can pituitary apoplex occur in SIH? What is wet and dry SIH? What is the blood volume use of EPB? What is hydrostatic indifference point? Is superficial cirrhosis is a clue? What is the age group? Can SIH present without headache? These are some commonest questions to be answered. And the last one is the most important question. SIH is a disease of the brain or disease of the CSF volume or disease of the CSF pressure or disease of the spine. That should be, I can answer that. Everybody will answer after the presentation. SIH epidemiology is actually disease of between 30 and 40 years, slightly female preponderance. One new things coming in their eyes, one should remember idiopathic intracranial hypertension, IIH or BAH is an emerging predisposing factor of for SIH. The diagnostic criteria, this is the diagnostic criteria, it has got many pitfalls. Orthostatic headache is the worst one. One pitfall is that many, around 40% many having orthostatic headache, but some may present without orthostatic headache, and sometimes chronic SH can have reverse orthostatic headache also. And other thing is low opening pressure. That is also a pitfall. Only up to 40 to 50% have low opening pressure, less than 6 millimeters of watt CSF. Around 40% be having normal CSF opening pressure and 10% be having high opening CSF pressure. That is also not correct. And the 2, 3, 4, and the most important thing for the diagnosis of SIH, that is MRI picture classical for spontaneous intracranial hypertension and demonstration of fast active CSF spinal leak and sustained improvement of symptoms after EPB. These are the 3 cardinal for diagnosing epidural spontaneous intracranial hypotension. And C and D should be there, definitely should be there. What are the predisposing factors? The predisposing factors are mainly the spinal pathology, especially calcified disc osteophytic complex, especially in the thoracic level. And minor trauma, especially most of the time it is unnoticed trivial trauma or a chiroptic manipulation. And some connective tissue disorder where the dura is thin or weak, like Marfan's Ehlers-Danlos syndrome or adult polycystic kidney. And one should remember the new thing is that BIH or idiopathic intracranial hypertension is an emerging predisposing factor for SIH. Even though this is a busy slide, this is the most important slide in this presentation. 3 things should remember for the pathogenesis. One is trivial unnoticed trauma to the spine, causing a dural tear in the thoracic region by a sharp disc osteophytic complex, producing a small leak in the dura or a leaking meningeal diverticula. Third is a direct CSF venous fistula. These 3 things cause continuous slow CSF leak to the extradural space or directly to the paravertebral veins, causing spontaneous intracranial hypovolemia, leads to loss of buoyancy and leads to brain sagging. One should remember Monro-Kelly hypothesis in this area. That is, the brain volume should be always constant. If there is any change in the bed volume of one compartment, it will be compensated by the other compartment. So intracranial hypovolemia leads to alterations in the equilibrium between the volumes of the intracranial blood, CSF, and brain tissue. Any decrease in the CSF volume leads to compensatory dilatation of vascular spaces, mostly on the venous side because of the higher complaints, leads to venous distension, rounding of the venous sinuses, and the venous sinus rounding and distension leads to slow flow in the venous sinus side, leads to venous sinus or cortical vein thrombosis, venous infarct, or cortical SH. And when the loss of buoyancy leads to brain or brain stem sagging, leads to chronic venous traction in the base of the skull, leads to microhemorrhages, chronic infratentorial, and sometimes supratentorial superficial hydrosis. And the brain sagging or brainstem sagging leads to classical postural headache due to stretching of the pain-sensitive structures. And the brain or brainstem sagging leads to posterior fossa crowding, tonsillar herniation, brainstem compression, brainstem symptoms, cranial symptom, cranial junction crowding, and sometimes bilateral pyramidal or extrapyramidal weakness. One should remember that these symptoms has got a postural change, classically increases during the erect or standing position. This is a cartoon show how this is a trivial trauma breach in the dura, CSF leak producing orthostatic spontaneous intracranial hypotension. This is the Monro-Kelly hypothesis. When the CSF volume becomes less, there is a compensatory dilatation in the venous space. These are the inciting events for a SIH. You can see how trivial the inciting event may be, like a stretching, coughing, vomiting, Valsalva maneuver, and chiroptic manipulation. Last week, a DM resident from Ernakulam came after a roller coaster ride in Vigaland with a classical SIH. This is also very important slide. What are the clinical presentation? Classical presentation is the typical postural headache that occur within 15 minutes of the erect posture. But after some time, the semiology of the headache changes, leads to second half of the day headache. That means that in the morning when they wake up, in the initial hours, there won't be any headache. They are very fresh. By 10 or 11 o'clock in the morning, they started having posterior head region, something holocranial headache. Okay, that is called the second half of the day headache. you can remember, you can imagine how the disabling that disease is. A employee is always normal in the morning hours and complains of headache in the peak working hour. It will be definitely interpreted as malingering. And chronic SIH after the initial posterior headache can turn up to be new onset posterior headache region headache, or can new onset post holocranial headache. And sometimes after the initial headache phase, that change to behavioral or cognitive symptoms like because of the frontal and temporal is gait disturbance, cranial palsies, NPS-like presentation. Rarely bibrachial amyotrophy because of the pure spinal variant. And sometimes they present with the progressive cerebellar ataxia and sensory neural deafness due to progressive superficial siderosis. These are the non-headache neurological symptoms common in SIH. The commonest non-headache neurological symptoms in SIH is mainly the radicular pain, cervical radicular pain because of the stretching of the cervical roots, and facial numbness because of the fifth nerve involvement, and vestibulocochlear symptoms as synesthesis. Remember, next time when you see a chronic SIH, there will be more than 50% be having facial numbness and vestibulocochlear symptoms, and other symptoms can go seen in non-headache neurological symptoms. What are the causes and complications of SIH? Spontaneous healing of a dural tear or other CSF leak like leaking meningeal diverticula or CSF venous fistula is usually rare. Majority leads to symptomatic spontaneous intracranial hypotension. After the initial postural headache phase leads to chronic non-specific headache. So the initial postural headache history is very, very important. The duration can be from months to many years, even up to 15 years. The brain stem sagging or brain sagging leads to the symptoms of cranial nerve symptoms or brain stem signs. The brain sagging leads to frontotemporal dementia-like picture. Venous sinus thrombosis, cortical vein thrombosis leads to venous infarct, and cortical SH leads to new onset seizures or status epilepticus. And sometimes bilateral subdural collection can occur, or rupture of the bridging veins leads to sizable subdural hematoma, and then that can turn fatal also. Once you suspect, the imaging strategy in our center is MRI brain plane and contrast, MRI whole spine screening, SAT space image, and a non-contrast MR myelography. These three are the three imaging modality we used to do. Almost 95% these three is suffice. In rare cases, we do CT myelography and dynamic digit DSA. Other three things we don't do. This is the classical imaging feature of a spontaneous intracranial hypertension. We can see the bilateral symmetrical subdural collection. And remember the third image, this shows a museum of finding spontaneous intracranial hypertension. You can see the venous sinus distension, rounding of the veins, the verticality of the straight sinus, and the brain sagging as evidenced by the splenial sagging and the mammillary body sagging, and the brain stem sagging. One important quantitative measure is that the pondo midbrain distance is more than 5.5. But in brain stem and brain sagging, the mammillary body sags down. Here it is actually sitting on the pons. There is no distance at all. Usually it is more than 5.5, it becomes less than 5.5. And when the brain stem sag, the pondo-mesencephalic junction will become less. And there will be posterior fossa crowding, and prepondine system become less, supracellular system will become less, and there will be pituitary hyperemia, and the tonsillar herniation. So this picture shows a museum of finding in SIH. And shows bilateral subdural collection. Here we can see straightening of the optic nerve. The perioptic sheath become chink, and the optic nerve become straight. And you can see when the brainstem sag, the anteroposterior diameter of the midbrain become more. and the interpedunculaar angle usually more than 40, that will become less, it is become more acute. So the interpedunculaar angle become acute, and anteroposterior diameter of the midbrain increases, optic nerve becomes straight, perioptic shapes become chink, and bilateral subdural collection on contrast and in administration. This is the classical picture and classical description: diffuse, near symmetrical, smooth wall, pachymeningeal thickening, and coronal image shows evil by night sign. This is the classical picture. And here the shows distance of the vein, verticality of the straight sinus, posterior fossa crowding, and tonsillar herniation and pituitary hyperemia. Just to show the difference between normal and NSH, this is the pontomesencephalic angle. Here it will become very less. Pituitary become hyperemic. There will be sagging of the splenium, and this is the pons and mammillary body. That this is more than 5.5, and this become very less. Here the mammillary body is sitting on the pons, and this is the interpedunculaar angle become very less, and there will be anteroposterior diameter of the midbrain will become more, and with the straightening of optic nerve in SIs as compared to normal person. Remember that brain MRI can be normal in 20% of cases. How the brain MRI become normal? Because of so many mechanisms, brain adaptation in chronic SIs. And one of the adaptation is called layer cake sign. It is more obvious in the CT film, where there will be more and more bone formation, producing the intracranial volume become the less. That is one of the brain adaptation to adaptive for the spontaneous intracranial hypertension. So the MRI brain can become normal after some time. This is the qualitative measures I told: mammillopontine angle, pontomesencephalic angle, interpedunculaar angle, and mammillopontine distance. And once you diagnose, we have to see the cause of CSF leak, demonstration of the CSF leak by MRA whole spine screening, fat sat space. This is typical in our Kurian's case. This is the thoracic spine, shows multiple disc osteophytic complex, and some of them are sharp, that is indenting on the dura. That produces a breach in the dura, leads to continuous CSF leakage to the extradural space. This is the extradural CSF collection in the anteriorly, and this is the dural collection in the posteriorly. Here you can see the dural collection anteriorly, that is seen in the you can see that in the transverse in this CSF collection. In this case needs some more little expertization from the interpretation. I will give you some clues. When usually the dura is always attached to the surrounding wall. When there's a spontaneous intracranial hypotension, the CSF leak is there. In the inside, the dura will become less turgid, and it will be close to the spinal cord, and we can see the spinal collection extra in outside, and the dura will be pushed anteriorly, and sometimes we can see the dura when it is pushed anteriorly, there will be anterior cord herniation. So we can see this line is the dura, and this is the CSF collection. When the CSF turbid will be less, and it is attached to the spinal cord, rather it is attached to the outside the spinal canal wall. This is the transverse section showing the posterior CSF collection. Here, this you can see the anterior CSF collection in the transverse section. This is a classical case. When the CSF space is extradural collection is more, this leads to it slightly push the cord anteriorly, leads to anterior cord herniation. Again, this can say this is the dural line, and this push the dura anteriorly, and the turbid inside the dural compartment will become less. Little more expertization is needed in interpreting the CSF spinal radiology. This is how we see the space. Fat space is important because sometimes the extradural fat is there producing this signal changes. To nullify that, we need a fat sat space. This is the dura pushing anteriorly. CSF collection we can see in more clearly in the fat image. So that is called, it leads to continuous CSF outside the dura. That is classically called SLUC, otherwise called spinal longitudinal extensive CSF collection. SLUG can be positive, it is called wet. It is negative, it is called a dry SIH. 5 types of CSF leak is there: type 1, type 2, type 3, type 4, type 5. Type 1 is the most common, that is because of the dural tear by calcified discostocytic complex, especially at the thoracic level. Type 2 is by leaking meningeal diverticula. It can be again type 2A, type 2B. And type 3 is direct CSF venous fistula. And type 5 is CSF lymphatic fistula. This is the pictorial representation. We can see this is the type 1, this is type 2, and type 3. Type 2 is leaking diverticula, type 3 is direct CSF venous fistula. And SLUG, I already mentioned, spinal longitudinal extensive CSF collection is seen classically in type 1. It is absent in type 2 and type 3. But it can be sometimes it can be positive in type 2 if the meningeal diverticula is situated inside the spinal canal. If it is away, it is negative. So classically, SLUG will be positive in type 1 and it will be negative in type 2 and type 3. Type 1 is around 90% and the second commonest is a type 3 around 20 to 30% and least is the type 2 and other two are very rare. This is the pathogenesis of CSF venous fistula, especially in the lower thoracic space. And the location of type 1, type 2, type 3. Type 1 is always in the lower cervical or upper dorsal, and type 2 is in the mid dorsal, and type 3 is in the lower thoracic level is the location of type CSF fistula, connection CSF fistula. And we do a myelogram also, a non-contrast myelogram to see whether there is any meningeal diverticula. This is another indirect sign which this doesn't carry much value. If there is a flowoid sign adjacent to thoracic discostocytic complex, we can indirectly say that is a site of leak. And with the brain MRI planar contrast, there's one new thing occurred. It's a Burns score in SH that we can predict the probability of a CSF leak according to the scoring system of Burns score in SH. Coming back to our Kurian's case, is a classical multiple discostocytic complex. He has got both anterior and lateral discostocytic complex indenting the dura. So it is a type 1A SLUG, type 1B SLUG, classical SIT is the clinical diagnosis of our Kurian. In Kurian, we treated with each word is very important: non-targeted, medium volume, autologous blood patch. Post procedure, very good relief of the headache. Second day morning rounds fully recovered. Second day evening rounds after 24 hours after the procedure, he presented very severe hollow cranial headache with a recurrent vomiting. Never experienced such severe headache in life. That got settled in 24 hours. That is classical paradoxical rebound intracranial hypertension following blood patch. The pathophysiology of rebound intracranial hypertension, if there is time, I will come back. Second important thing one should remember, what is the CSF profile in SIH? Almost all patients, nearly 100% will be having CSF abnormality. Cells up to 200 cells and protein up to 1000 and xanthochromia is reported. These are the mechanism because of chronic meningeal inflammation by traction, increased permeability of the dilated meningeal vessels, and decrease lumbar CSF flow in the lumbar subarachnoid space act like a mimic CSF block, a Freund syndrome. We only did only in 4 cases because of the lack of diagnosis, and all patients have got CSF pleocytosis and rise CSF protein. These are the complications of spontaneous intracranial hypotension. They can have a subdural collection sizable and subbilateral sizable subdural hematoma and brainstem compression, brain sagging syndrome, frontotemporal dementia, and cranial symptoms, and tonsillar herniation, and pyramidal and extrapyramidal symptoms, and bilateral subdural sizable life-endangering subdural hematoma. And this is a particular sign we used to call, if it is there, no doubt it is SIH. This is what is called, we used to call, not reported, it's a monkey head appearance in the brainstem. Monkey's face or head appearance. If this is there, it is SIH because of the classical of brainstem sagging. This leads to brain stem syndromes, cranial nerve symptoms, and pyramidal symptoms as the cause a complication. We can, in all cases, we see the typical monkey's face appearance in the brain stem. And another important complication is that around 30 to 40% we can see venous sinus thrombosis, cortical vein thrombosis. Venous, in fact, leads to new onset seizures, status epilepticus, and even can lead fatal. And frontotemporal brain sagging syndrome, frontotemporal dementia, bilateral pyramidal or extrapyramidal dysfunction, and NPS-like presentation. And this is another very important complications in untreated neglected case of SIH or misdiagnosed SIH leads to severe infratentorial superficial siderosis. And rare clinical presentation in our case series is a 55-year-old gentleman is a progressive cerebellar ataxia and sensory neural deafness for the past 12-14 years. He gives history of postural headache lasting for few weeks, that is 14-15 years ago, following a minor road traffic accident. That was treated as migraine by the neurophysician there at that time and got subsided, and subsequently he and family ignored about that incident. 2 to 3 years after that trivial trauma and if trivial postural headache phase, he noticed progressive ataxia and sensory neural deafness. Severely disabled and he lost his job. And MRI showed classical chronic SIH. MRI whole spine screening even after 15 years showed features of slug after 15 years. This is the MRI taken after 15 years. He recently came around 5 months back. This is the MRI picture of a chronic SIH, shows the chronic callosal, chronic splenial sagging, and the brain CSF hypovolemia or hypotension producing jinking of the ventricle and some amount of brain after because of the cirrhosis by some amount of the brain atrophy, and the brainstem sagging symptoms, brainstem sagging signs may disappear, and the chronic SIH symptoms will be classical like this. This callosum will be like this callosal and splenial sagging with the loss of CSF volume, and that patient showed even after 15 years persistence of slug in the cervical and not in the cervical region, entire spine there is slug. And his MRI show classical, very severe, both infratentorial and supratentorial superficial siderosis of brain. He presented with the progressive cerebellar ataxia and sensory neural deafness after 2 to 3 years after the initial trivial fall. And this is the case, and he had and he also treated with a blood patch, and after 2 to 3 weeks, he improved dramatically. And this is another rare clinical presentation complication of SIH. This is a pure spinal variant. He repeated cross questioning or repeated clues. His complaints, so he had a postural headache 5 years ago. He was getting treatment as bibrachial amyotrophy due to either a brachial neuritis or MND. But his imaging shows even after 5 to 6 years, classical slug producing compression of the spinal of the cervical spinal cord. This is a pure spinal variant as bibrachial amyotrophic variant of spontaneous intracranial hypotension. So many reports are there about the pure spinal variant of bibrachial amyotrophic variant of spontaneous intracranial hypotension. This is another rare presentation in our series. This lady is a staff nurse working in Saudi Arabia. She presented the classical spontaneous intracranial hypotension history, and slug is present, but MRI brain showed no Pachymeningeal enhancement, only leptomeningeal enhancement, and CSF study shows cells. And this is all the way it is, there is a tendency to treat it as a meningitis, but slug is present, history is very typical. So even though brain MRI is not suggestive of shows leptomeningeal rather Pachymeningeal enhancement, she got treated, and within 24 hours all her symptoms subsided. This is another presentation. He had a trivial trauma, presented the sizable unilateral subdural hematoma with a slug, and he needed urgent evacuation of the subdural hematoma, and later treated with the blood patch, and he improved very well. So remember, even post-traumatic unilateral subdural hematoma can be a complication of spontaneous intracranial hypotension. Because if you treat only the subdural hematoma, definitely he will come with again bilateral subdural collection. So treating underlying pathology rather blood hole evacuation is also very important. So what are the misdiagnoses of spontaneous intracranial hypertension? With so many series shows almost 90% initially received an incorrect diagnosis. Common clinical misdiagnoses are migraine, vascular headache, meningitis, acute status epilepticus due to encephalitis or psychogenic disorder or benign intracranial hypertension. Misdiagnosis for migraine, the importance is because the treatment used for the migraine, the topiramate and Dimos, can further aggravate the disease course. And the radiological misdiagnosis is subdural hematoma, subdural hygroma, Arnold-Chiari malformation, venous sinus thrombosis, pituitary apoplexy, subdural emphysema, idiopathic hypertrophic pachymeningitis. That is why I told the symmetrical smooth wall pachymeningeus thickening is for SIH. Asymmetrical from the above. This typically this is the brain sagging, typical monkey head appearance, and this is the brain pushing from supratentorial compartment by the mastition or a pressure in higher pressure in the supratentorial compartment. What are the treatment protocol we use for SH? Conservative trial in selector case, milder case only for we can wait up to 2 to 3 weeks. If fails, non-targeted medium volume autologous blood patch is the mainstay of treatment. If that fails, non-targeted high volume blood patch. If that fails, targeted ultra low volume blood patch. If that fails, targeted fibrin glue is the. If that also fail, we have to see for the main further evaluation needs the correct location, surgical correction, and if we demonstrate a CSF venous fistula by a dynamic DSA, leads to venous side embolization. Definitely treatment of all SIH related complication. What is a conservative trial? One may ask. May be effective up to 20%. Strict bed rest, plenty of hydration, plenty of coffee, theophylline, and sometimes we give fluorocortisone 50 microgram per day. Corticosteroids, some used prednisolone, IV Dexona, even IV methylprednisolone trial was there, and abdominal binders are the conservative trial. You can try up to 2 to 3 weeks. But spontaneous intracranial hypotension, blood patch is the treatment of rule. This is first line of treatment for SIH. If you diagnose SIH, this is the first line of treatment. The mechanism of leak closure by CS by the EPB is once you do BPB, there is a direct interaction of injected blood as a anticoagulant component of the CSF emanating from the dural defect leads to clotting of that injected blood. Then that acts as a buttress upon the leak, and the integrity of the dura can be restored. That is the first mechanism. Second mechanism, if you inject in the epidural blood patch, that causes cephalad displacement of the CSF, already existing CSF, removing pressure from the leak site. And by reducing the pressure grade between, the third mechanism is the pressure grade between the subarachnoid space and extradural space by injecting more volume of blood. That also reduces the CSF leak, and that leads to spontaneous healing as well as the buttress healing by the blood patch. That is the mechanism of blood patch. How we do blood patch, because it can be targeted or non-targeted. It can be a blind procedure or it can be a fluoroscopic guided procedure. It can be, if it is non-targeted or targeted, it can be a single lumbar site or can be double, or either lumbar or thoracic, two sites can be used. After the procedure, keep the patient in the tenderloin position for 2 hours for the cranial movement of the injected blood. If there is no contraindication for that typical position, but because if the ladies have got a venous sinus thrombosis, or lady is on OCP, we avoid this position because that can precipitate a deep venous DVT. And after the procedure, after the 2 hours in that particular position, then keep the post procedure flat for 48 hours. Avoid valsalva maneuver and physical stress for the next 6 weeks. And repeat EPB can be done if first EPB fails after 2 weeks. So we follow the rule of 2. We do 2 hours in the tenderloin position, 2 days complete rest, 2 weeks we can repeat if needed, and 2 months relative rest. We use, if ultra low volume, medium volume, and high volume can be used according to the situation. The success rate of first TPB is more than 70%. Is common adverse effect is very minor. Serious adverse effect also very minimal. Sometimes rarely they can have rebound intracranial hypertension up to 20% of cases. In our case series, we have 66 cases. 61 cases we did a BP batch, 5 cases we did not improve with the conservative trial and some lost to follow. Slight female preponderance, mean age is around 40, duration of presentation up to 3 months to 12 to 15 years. That last one was 15 years. Mean duration 6 months. Male female ratios. This is the radiologic clinical presentation. All had postural headache at onset at some time of the history, and the new onset recurrent seizures in around 40% of cases, recurrent seizures, and status epilepticus in 5 patients, cognitive decline in 2 patients, and meningitis like picture in 10 patients. And radiologic findings almost always same. 16 patients had venous sinus thrombosis, cortical vein thrombosis, and cortical SH. And SLUG was positive in 61 cases. And 6 has got sizable bilateral subdural hematoma, needed urgent Barhol evacuation. And 2 had unilateral sizable subdural hematoma. And typical, and in 2 patients, we had leaking meningeal diverticular, there was no SLUG. And 5 patients, no SLUG, and CSF diverticular also not demonstrated. That may be because of the direct CSF venous fistula. And epidural blood patch, we do non-targeted medium volume. Each word is very important. Non-targeted medium volume autologous EPB we use. 61 cases. Only 2 cases needed dynamic DSA followed by targeted blood patch. That is that I previously told 2 cases, maybe because of the direct CSF venous fistula. That case, the dynamic DSA was done and demonstrated a CSF venous fistula and needed appropriate treatment. And EPB success rate was 100% in our case series. Only 2 patients needed successive 2 sequential blood patches. It is from my word, it is, and from my experience, it is a very safe procedure with a dramatic, rewarding, and immediate result. One patient after the 24 hours post-procedure had a classical rebound intracranial hypertension. Not even a minor complication in the rest of the case series. And that was my idea till 2 months, 3 months ago. And one lady completely improved and discharged hope and came after 1 month with the features of hydrocephalus, and she had a hydrocephalus that also subsided and treated very well. So that, remember, that also, that kind of complication also occur after the blood patch. And this is another complication we occurred. This is not a true complication of a blood patch, but a complication of the procedure. This lady from Trivandrum gave the classical features of spontaneous endocrine hypotension with the SLUG was positive, and we attempted blood patch, but finally we abandoned because of the severe pain. And that night she had a troublesome headache, and urgent CT head was taken that showed pneumocephalus. because that is a procedure-related complication, not a complication of blood patch. And that also lady, and tomorrow, next day morning, we targeted under guided and fluorescent guided EPB was done and completely recovered. So after the procedure, definitely everybody will be able to answer the questions. Like what is the commonest clinical presentation of SH? What is the commonest radiological picture of SH? Can venous sinus scotic vein thrombosis occur in SH? Can behavioral or cognitive decline occur in SH? What is frontotemporal dementia syndrome? Can pituitary apoplexy occur in SH? What is wet and dry SH? What is the blood volume used for SH, EPB? What is hydrostatic indifference point? Is superficial sclerosis a clue to chronic SIH? What is the age group? And finally, the last important question. Is it a disease of the brain, disease of the CSF volume, or a disease of the CSF pressure, or a disease of the... It is definitely a disease of spine. This is a very useful helping point I can give you, because this first set is a very clear cut. New onset headache and other symptoms. Classical history, brain plane and contrast is positive. Pulse spines finish show, that is also positive. Classical SH, go for APB. Classical history, brain negative, pulse spine screening positive. That means up to 20% brain can be negative. So it is SH, go for EPB. Classical history, brain positive, but spine is negative. That also possible, because SLUC will be positive only in type 1, type 2, type 3, it will be negative. So brain classical history, it is SH, go for EPB. Classical headache history, brain negative, whole spine negative. In that case, that also possible, because brain can be negative in 20% and spine can be negative in type 2 and type 3 CSF leak. But history is very classical. You try conservative trial, and if fails, go for a SH. This area is very clear. But another stage where non-specific chronic headache with the postural headache at the onset, or second half of the day headache, or new daily persistent headache. In that scenario, if brain is positive, whole spine is positive, go ahead with the SH. If brain is negative, whole spine is positive, again go ahead. If brain positive, spine is negative, because spine is negative in type 2 and type 3. Go ahead with SIs. But in that set of patients, if brain is negative, brain MRI is negative, whole spine MRI is negative, that is called true double negative case. In true double negative case, I already told, CT myelography and dynamic DSM. CT myelography only we do, single CT myelography. We never do a dynamic CT myelography, because it is cumbersome. It is very radiation exposure. So we do dynamic digital subtraction myelography. That is, the yield is very good. That will show leaky meningeal diverticula and direct CSF venous fistula. If that is negative, that is CT myelography or dynamic DSM is negative, we have no proof for SIs. But justifiable if other therapy fails. If positive, it is SH, need either targeted blood patch. Here it is not non-targeted. Here we have to give targeted blood patch or targeted fibrin glue. If it is a direct CSF venous fistula, go for venous side embolization. Now, after hearing all this is question to the audience. What is, if postural headache or CSF hypovolemia syndrome is common in CSF rhinuria, CSF photoria, or post-traumatic CSF leak? Is it common? Is it common? That is first question. Why we are selecting 20 to 25 ml of EPB as medium volume? What is ultra? What is low? What is medium? What is high volume EPB? That is a question to you. And this is the carry home message. That is my final slide. SIH can have varied presentation. Postural headache may be present during the initial phase only. Long duration, up to many years, can have multiple and life-threatening complications. May turn fatal. Proper and timely suspicion and diagnosis is very important. Both initial clinical history and careful radiological picture is very important. completely reversible if diagnosed properly, doesn't hesitate EPB if a diagnosis is certain with a slug or clinical suspicion is high. Only one therapeutic procedure in neurology carries very high success rate, up to 100%, is EPB. The better terminology is spontaneous venous CSF hypovolemia rather than hypotension. So many so-called chronic TVH or chronic CDH, chronic daily headache, can have underlying substrate, needs evaluation before labeling them as non-organic. This is our SIS team, and I think I have done justice to my heading, often underdiagnosis, undertreated, but potentially treatable, reversible headache, journey through our experience with the learning points. Thank you.
Thank you, Parameshwaran. An excellent presentation. You have covered all parts of this disease very well. You have given a lot of practical tips also. I have got few questions to you. One thing is there are mainly 3 types of CSF leaks. Will all these leaks will respond equally well to EPB?
Definitely, but if CSF venous fistula is there, that may need a venous side.
I can't hear you. I can't see you.
Are you there?
What has happened?
Okay, there are a couple of
Yes.
How about you, man?
Hello, what has happened to you, Paraben?
So,
Can you hear me?
Yes. You
Okay.
are back.
Sorry.
Yes.
Just 5 minutes. Okay. Tell. Okay. Sorry. Tell me. Some practical
Okay.
connection
That you
problem.
have already answered. You told that all 3 types will respond equally to blood patching. And
Yes, the venous fistula sometimes may need a venous side embolization, but usually it will respond.
okay, what's the chance of recurrence following blood patching?
70 to 80% is the first step. Blood patch is the success rate. Sometimes may need a second batch.
Okay. See, this SH has got non-complications like subdural hematoma and a cortical vein thrombosis. Suppose if the patient has got subdural hematoma of sizable size, say more than 10 millimeter thickness, and there is indication for evacuation, will you do blood patching first or evacuation of the hematoma first?
Evacuation first, no doubt, followed by blood patch.
See, if you are doing evacuation, you are giving more negative pressure, isn't it?
But we have time for treating SIs. But subdural hematoma, sometimes they will cone immediately when we are seeing. We have no time to. When we are buying time, we have no. We cannot go for another. We have to, if it is a dire emergency, we have to do blood patch first. If patient is stable, definitely the reverse we can do.
And also regarding cortical vein thrombosis, is it safe to start on anticoagulation?
It is very safe to say anticoagulation.
Anticoagulation. Okay, okay. You have done the job very well, Parameshwaran. Excellent job. Definitely, it has helped all of us. Very good. Keep it up. Hope that we will have more talks like this from you.
Can I have 2 minutes?
Yeah, of course.
1 minute. Can I have?
Yeah, of course.
Carry on.
So all the questions I answered is actually everything everybody answered. Just 2 questions, only 1 minute taken after the presentation. Where everybody should answer what is the burn score in a sprint? Question answer: probability of identifying CSF leak, probability of CSF venous fistula, severity of SH complication, response to EPB, all of the above. Answer is probability of identifying CSF leak. Another true double negative chronic SH can be seen in type 1, type 2 CSF leak, type 3 CSF leak, type 2 and 3 CSF leak, all of the above. It is seen in. Answer is for type 2 and type 3. Another question that is very important practical for everybody. CSF pleocytosis with a high CSF protein in suspected chronic SIH is question answer 1 is rule out SIH 5 to 10%, 20 to 30%, 50%, more than 90%. Answer is CSF pleocytosis in SIH is almost 100%. Fourth question is success rate, that you already answered the question of non-targeted EPB of first is in classical SIH, the select of the first EPB is 10, 20, 30, 50, more than 70. It is more than 70. And last question is buoyancy period point. Otherwise, we call it as the hydrostatic indifference point is located above craniomedullary junction, cervical, dorsal, lumbar, none of the above. It is lower cervical or cervical dorsal junction. Why? Okay. So it's only question after the presentation, just for a follow-up. Okay.
Thank you, Parameshwaran. Over to Asha.
Thank you, Parameshwaran, for that very lucid and
Ashaji Kekamala.
yeah, thank you, Parameshwaran, for that very descriptive narration of all the points. At least for me, 50% of the things are very new. I'll go back and read, especially your buoyancy point, burn score, and all. And I'm hearing for the first time. And I'm really, really grateful to you that you came out with this. The great collection of your cases. Sitting in a, you know, that when you were here also, we would have hardly seen 1 or 2 patients, and maybe 1 patient per year is the usual fallout here. But you have given a very vivid description and narration. Thanks a lot. And the final MCQs were an icing to the cake, and very, very well done. And Sanjeev too, thanks for being the chair of the session. And he too is an ustad in SIH, you know that. And both of you have been very kind to be here from 8 to 9. And this will be put up in the YouTube channel as well. So thank you from the whole department towards both of you, especially Parameshwaran, for taking your time out and coming out with a wonderful presentation. Thank you so much. Okay.
And thank you so much, Asha madam. Thank you so much for patiently hearing me. Thank you, Sanjeev, for chairing the session. Thank you, Asha madam, my mentor, my guru from my PG day onwards. Thank you. Thanks a lot for giving me this opportunity.
Thanks a lot.
Okay.
We
bye.
can close the...
Yeah, we can close.
Okay, thank you.
Bye. Bye.